Welcome to the next episode of the Existential Files. Hello, Louie.
Hello, Matthew.
Yeah, you see, I have to always kind of get this upbeat feeling because this obviously it's the feelings I have inside. You know me, Louie. You know that I'm constantly this upbeat person, and I never have any kind of so-called negative emotions or challenging anxiety experiences. So I like to start each of the episodes in that way. But lovely to join you again.
It's only
been a bit of a time since we've done one of these ourselves.
Well, I was going to say, if only our listeners knew that I would say I'm probably the more upbeat of the two of us at the moment.
At the moment, absolutely. But it changes. It's the ups and downs of life. However, Louie, let's cut to the chase.
Yeah. So today we are joined by a guest. I mean, I booked this guest, I think, a couple of months ago now, and we've been trying to get him on a few times, but events have got in the way. But today we are joined by a very special guest, Dr. Jeffrey Schaler. I think that's right. If I don't pronounce anything right, Jeff, please correct me. Because actually, the first thing, before I introduce you, the first question is, how do we pronounce Thomas? See, now we have been saying it. We've been discussing it with ourselves for ages. We say Szasz, and I think that's wrong. I think I was looking at your website, and I think it's more Szasz. So could you enlighten us?
Well, he instructed everyone on the pronunciation to think of Szasz as in Saskatchewan. That was the key. But in my
doesn't help me a lot.
I know it never helped me either, so I just I call him whatever I want. I say Szasz, and in the book that I did about him and with him called Szasz Under Fire, we do have his phonetic construction of how to pronounce his name. So just think Szasz like that, not sass as in sassy, but Szasz will do it.
Well, that clears that.
It's a Hungarian.
Yeah, that clears that one up, because I know that, I mean, I've been discussing this with people and we have absolutely no idea how to say it. So that actually clears it up. So today, if I give you I'm going to read your bio, Jeff, because you've got a lovely little bio. So I'm going to introduce you.
Sure.
It says, Dr. Jeff Schaler is a psychologist in Maryland, United States. He taught at American University's School of Public Affairs for 27 years as a full-time professor and all aspects of psychology and addiction for 10 years at Johns Hopkins University. He continues with his private practice now after 40 years, and his latest book with Richard Vatz and Henry Lothane is entitled Thomas Szasz, The Man and His Ideas. So, and Jeff is holding up the book. Unfortunately, the viewers can't see it. Our podcast listeners can't see the book, but we'll put a link. We'll put a link on the podcast episode.
Yes, I'm very pleased with it. It's turned out very well, and so are my co-editors. This was my baby, but they helped in important ways, and the articles are all unique, all brand new, and I think we've really done a good job applying his ideas. One, explaining his ideas, and two, applying them in new directions. And also, as strong advocates and friends of Tom's, we take issue with Tom on certain things, which I'm glad that we do. It's not just a toady, obsequious type of story. It's certainly not a festschrift, but it is, I think, a very stimulating book, if I don't mind saying so myself.
So Jeffrey, for people who, I mean, I've been discussing this with people for a while now, and I don't know, I mean, I think you might be, are you surprised that a lot of people haven't heard of Thomas Szasz and the myth of mental illness? Because, you know, when I discuss this with other psychologists and psychiatrists, there are a hell of a lot of people that have no idea about this book. And, you know, in my mind, I think this is an absolutely important book for people to, read and understand. So, I mean, to start off with then, I mean, should we discuss some of his, what is the basic idea in that book?
Well, let me mention one thing in terms of how much people know about him in general. There's a saying by one psychiatrist, many people have heard of Thomas Szasz, but very few have actually read or understand him. For example, people who are critical say, how can he say there's no such thing as a mentally ill person? No, he's not denying the existence of people who get labeled or, quote, diagnosed as mentally ill. What he has done is say, There is no illness or disease called mental illness, as in schizophrenia, addiction, manic depression, all the categories that we're familiar with. He says, no, these are not real diseases the way we categorize physical diseases. And physical diseases are known primarily by lesions or wounds in the cells. Some kind of problem in cells constitutes it as a disease. This is one of the reasons why all of the, quote, mental illnesses are not listed in a standard textbook on diseases. They don't meet what's called the criteria for nosological classification, which means there has to be something physical there. There are a few diseases that we don't know what the physical cause is, like, say, in migraine or some other diseases. And it's not all the way true with migraine, but generally we discover that something's a disease by looking at it under a microscope and seeing the flaw in the cell. And this is simply not true for the mental illnesses.
But then can I ask then the question then?
Sure.
In terms of, and again, it may be a very naive question. So you're very clear then focused on distinguishing it from disease,
yes,
but still the term of illness, because the term we would usually refer to as someone, in quotes, suffering from mental illness, or
right,
described as mentally ill. So therefore,
right,
the notion of illness or
right,
ill health. So the kinds of things we might describe and often are diagnosed as mental illness.
right.
Is there still an issue there? Would you still have a problem in terms of referring to them as illness, or simply that they are incorrectly conceived as being something akin to a disease?
Well, these are what we call metaphorical diseases, that people consider them like a disease, but they're not the same as a disease. And there are two very, very important aspects to calling something a disease that bears on the individual. One, the person is absolved of responsibility for having the disease, and he is excused from responsibilities because of the disease to varying extents, as long as he tries to do something about it, the disease. And in that sense, saying that someone is mentally ill absolves them of responsibility for bad things that they do, especially breaking crimes. And the idea of mental illness is used to deprive people of responsibility. You aren't really guilty of killing this person because you were mentally ill. And also it's used to deprive people of freedom. And that's when they have not committed a crime. So what Thomas Szasz liked to say was, a person, when in the insanity defense, a person committed a crime but is treated as if he's innocent. And in involuntary commitment, where someone is swept off the streets and forced into a mental institution, a person is treated as if he is guilty of a crime when in fact he is innocent. So there are very serious ramifications to saying that somebody is sick. And that also bears on, I'm sure you've heard of Talcott Parsons and his sick role, the sociologist. And he echoed this too. He said, it's not your fault that you have cancer. And yes, there's certain activities that could increase the probability of cancer, like smoking, but it's not directly your fault. You can't will the onset of a disease any more than you can will it away. But if you have a disease, you have a responsibility to seek help if you want to have other responsibilities given up. For example, if you're not going to go to work, or you're not going to do X, Y, and Z, then you've got to go and try to get help. One of the key things here, too, is that people use mental illness because there are no signs or physical signs. They're just symptoms, which are subjective. And we can't tell whether someone is malingering or really sick. The only way you can really confirm this is through microscope and certain tests that say there's a blood problem, there's a bone problem, whatever it is. So malingering has been very closely connected with diagnoses of mental illness. It's easy to fake.
Absolutely. And to some extent, then you're mentioning some of the legal ramifications of these kinds of questions. So this idea of responsibility and freedom. And in many ways, I'd see these touching upon the kind of existential questions that Louie and I would like to ponder on the podcast.
Yes.
Both Louie and I have the background in psychology, so
Right.
therefore, to some extent, even just stepping away from those ramifications, in terms of a potential understanding of when people are, and I often go back to experiences, experiencing something that traditionally so far we may diagnose and therefore label either as a certain type of mental illness, or often within psychology you might talk about a psychological disorder.
Yeah.
I mean, do we have some understanding of, are we still at the place where we just simply have no idea what's kind of at the root of those kinds of, in quotes, illnesses, disorders, experiences, and therefore we just have to be very, very careful of how we categorize them for the reasons that you outline?
Before you answer that, Jack, I mean, can I just, I've just got a couple of lines from Szasz here, and he says, I view hallucinations as disowned self-conversations and delusions as stubborn errors or lies. Both are created by the patient and could be stopped by them. And I think that's pretty clear what he's getting at there.
Yes, yes. Another way of describing a hallucination is, which I prefer, is a self-reported imagining. For example, if I say that there are pink elephants crawling on the ceiling in my office, that is an imagining, and I'm reporting it, and no one can confirm it. Now, there's no evidence to support the existence or the reality of that. And hallucination as a self-reported imagining is key to most diagnoses of schizophrenia, as you guys know. The thing here is that if the self-reported imagining is socially acceptable, then there's no problem. For example, if you say, Jesus has entered my heart, or I'm having a religious experience, which is a hallucination. If God is watching over me according to my beliefs, and I say I see Jesus in the air, whatever, then that's a hallucination. It's one that we tend to leave people alone with. But if you say that a cat told me to kill this person, that's a hallucination that's socially unacceptable. And unfortunately, people get off of responsibility because as soon as they say that, people say, well, he's schizophrenic. The thing that I've always pointed out is that why is it that he has to do what the cat says? Are you with me?
Yeah, sure, yeah.
Yeah. I mean, people say, well, the cat told him he's imagined this, so he has to do it. Well, that's nonsense.
So then, Jeff, I mean, we had a guest, I think a couple of episodes ago, and he was, a complete denier of free will.
Yeah.
And, I'm an existentialist, so I believe entirely in free will. And again, for me, my feeling is that existentialism, free will is runs through the heart of Szasz's work.
Absolutely.
And that, to deny those things is to deny our complete power that we have, which is at the same time terrible. It's a terrible power, freedom, isn't it? As well as powerful,
Exactly. Yes.
And so you would agree then to some extent that, I'm interested in whether you think this is the downfall of religion, the upsurge in psychiatry.
Right.
I mean, psychiatry is the religion of the modern age.
Exactly. In the United States, talking about mental illnesses and the power that psychiatrists had coincided somewhat with the establishment of the Bill of Rights and the separation of church and state. The priests became, the psychiatrists became the new priests. And there's a very close relationship here. And Thomas Szasz wrote about this in a lot of his books. One of them is Ceremonial Chemistry, where he talks about how people who use illegal drugs are being persecuted for essentially religious reasons. Moral agency, though, is at the core of Tom's ideas. And it's also at the core of what we consider to be human. We choose. Now, all of the ideas surrounding mental illness refer to man, in the generic sense, as a machine. He doesn't choose. All actions are considered the result of chemical and electrical interactions. Man is a machine, an incredibly complex machine, but a machine nevertheless. But when you talk about freedom and the fear of freedom, that's the door for me in terms of existentialism. And I consider myself an existential psychotherapist or psychoanalyst myself. The main things that I think influence behavior are fear of death, fear of meaning, fear of freedom, and fear of isolation. And the issue of fear of freedom is where people seem to want to give power over to others. First, it was priests, although they still do that. And now it's psychiatrists who seem to be experts in the minds of other people about the nature of what it means to be human. Of course, they don't know much about that at all. And but they're given a tremendous amount of power, as you know. And Tom and I and people in that camp have been working very hard to bring an awareness about this to the public, because it's too much power. It flies in the face of the rule of law in a country that values freedom.
Can I ask a question then in terms of treatment, I guess, then? So, and it may be in terms of your own work. So somebody who, because again, I think very much we're talking about then, at the root of some of this is, you use the phrase then moral agency. I think that keyword also is responsibility. Right. So this idea that often when people are diagnosed or treated in such a way and labelled with, in quotes, a mental illness, right, then it has the impact on how much responsibility they have for their actions. And absolutely, we can then discuss some of those elements. Right. I guess I'm still coming back even a step from that to saying, okay, well, and part of it is because we don't really understand what these kinds of things are, whether they are, we've said maybe not disease. Illness is also a challenging word to use. Disorder is often a term we see within psychology. Right. So, but in terms of then treatment, if someone's presenting with these kinds of experiences, and maybe in your context as a psychotherapist or analyst, right, is what would part of that treatment be? How could we help somebody who's saying, well, I'm having experiences which at least feel as though they're happening to me, that I don't feel responsible for. How do I manage them? How do I work with them?
Well, first and foremost, treatment, which is a bit of a misnomer because it implies a medical type of interaction and usually calls into question the nature of disease, or disease as some kind of prime mover. All treatment must be on a voluntary basis. In other words, when somebody says to Tom Szasz and to myself, what would you do if I brought you someone who chewed off his fingers? And Tom said, I don't work with people who are brought to me. If this fellow wants to come and work with me, perhaps I will work with him. But I don't have an obligation to work with him. This isn't like somebody who comes to an emergency room and is bleeding and you have to fix him or heal him or treat him. No, it's different. Here we're talking about an existential experience. And Tom used to say, there's no emergency when it comes to an existential experience like this. What might be considered an emergency would be a threat of suicide. Now, Tom's position on suicide is that a person has the absolute right and freedom to commit suicide. In fact, he committed suicide himself. And that's Albert Camus once said, there's only one true philosophical question, and that is whether or not to commit suicide. And Tom wrote a lot about suicide because it encompasses everything that's self-destructive. Does a person have a right to self-destruct? Yes. Although in the United States, it's against the law. It's not really against the law in the sense that it's a legal thing, because obviously if you succeed, there's nothing that they can do. If you fail, you may very well be put into a mental hospital and deprived of freedom on that basis. But Tom's idea, and I don't think he's lacking in compassion at all. Certainly he and I have worked with people that wanted to commit suicide. And how do we do it? We talk to them and we listen to them. And as you know, as a psychotherapist, there are all different ways of helping somebody. You have to zero in on what they can hear and what they can use in terms of the conversation called psychotherapy. There's no medicine. Conversation is not literal medicine. It's metaphorical medicine, and it can be very useful. Just like going to graduate school can be very, very useful, but you're not being treated for something, right? You're learning.
Absolutely. So in terms of some of therapeutic basics, as it were, or fundamentals, is it just allowing and helping someone or giving someone the space to explore their experience, accepting it, looking at strategies to manage it, rather than anything that could be described as as I say, I use that term, treatment. And again, because of course, actually, in terms of the way that national health services are running, or different countries are responding this way, absolutely, it's the context of the medical model and treatment, and often drugs as a way of actually trying to not necessarily make or help people, just to almost keep a containment on it and manage some of those symptoms.
Exactly.
Although, I mean, if I can interject, you might say that psychiatry has pulled a great con job on everybody, and how do you question? I mean, we're talking about religion. At least questioning religion seems something that we're able to do at the moment. I mean, questioning psychiatry, I think, it seems almost like they've won the war. Correct.
In fact, if you're accused of being mentally ill and you say there's no such thing as mental illness, that's taken as proof that you're mentally ill.
You can't win.
You can't win. It's like during the Inquisition. One of the chief symptoms, or they called them signs, but it's not a sign, of being a witch is to deny the existence of witches. You got into big trouble if you did that. So yes, it was kind of a heads I win, tails you lose situation. But the first thing to think about in terms of treatment is, one, that it's voluntary always, and no coercion at all. That was Tom's position, and that's my position as well. How could you coerce somebody into confession? That's got to be a very spontaneous, honest type of expression. You can't twist someone's arm and say, tell me what the truth is about you, as if that's going to help you. I mean, you're both therapists, right? So you know what you can't get very far by pushing somebody in that way.
And also, let's make clear, well, we're not therapists, actually. Absolutely. So in terms of my background both Louie and I have similar backgrounds in terms of degrees in psychology and PhD, so in research in that area. Uh-huh. I work as an academic, so I'm mainly teach and research. So it's not, so I don't work as a therapist.
Okay.
However, familiar with much of what you're talking about, but that's why I think it's really interesting to know how one may, in the context of working in a broadly therapeutic environment, is if one is working with people or anybody who's having these kinds of experiences, what would be the approach you're advocating? And I'm reflecting on how that sits within the broader framework, because again, we're finding that issues of, to use another term, mental health issues as a way of trying to, because and again, often when we use the term mental health, we often tend to be about mental illness or mental ill health, or when people are having mental health challenges or problems, or whatever current terminology we're trying to use is to describe people who, actually it's a wide-ranging thing. If we're including things like anxiety, depression, all the things that many of us experience from time to time, is that also a core of it, by saying a large amount of what we may typically label under mental health issues are actually things which apply to us all much of the time, rather than a group of people who are, in quotes, suffering from mental illness.
Well,
exactly.
If I can just interject, Matt. I mean, what I take from Szasz's work is that, these are existential problems that we all suffer from, and that, being alive and being an existential being is a difficult thing. And some people express that difficulty in ways that, we might classically identify as mental illness. But,
But then is there a case then, so we mentioned briefly things like schizophrenia and hallucinations, which is obviously one of the big, I'm going to use the word symptomatic of I get often very careful the words I'm using, but symptomatic of things that are typically now described as schizophrenia, as though it is a coherent entity that we can label as such. Yet at the very least to say that absolutely the kinds of things we're all filled with existentially is something we can all touch upon.
Yes.
And are we seeing then that hallucinatory experiences is one response to that existential experience?
Yes.
As opposed to being indicative of anything else? Because again, Louie and I have spoken in the past about taking drugs and the impact that has on experiences such as hallucinations.
Sure.
And therefore, the differences between those kinds of experiences, the experiences of people, in quotes, suffering from psychosis, and your wording there, I think it was self-reported imaginings,
yes.
which to me, again, I want to sort of say that feels as though that has a sense of, whilst we can definitely have a sense of, I know what it's like to imagine pink elephants crawling across the ceiling. Right. If I was having an experience that would normally be labeled hallucinatory, my experience is such that I am seeing those things. They are there.
Right.
And that therefore feels much more dramatic and much more vivid and real, in quotes, than something that could be labeled as a self-reported imagining.
Right.
So I'm just wondering, are we still seeing those kinds of experiences sitting within essentially just this is a one normal response to the experience of being an existential being?
Right. Well, let me clarify a couple things. One, in terms of the task of psychotherapy, there are three basic rules. One, absolute confidentiality. Two, no dual relationships. In other words, you work as an analyst or therapist and you don't have sexual relationships with a client, you don't perform weddings for them, you don't socialize with them, etc. It's a very disciplined work. But beyond that, Tom never gave instructions. I said three, I mean two. Oh, well, in the United States, they consider it an absolute must to take notes. So if you don't take notes, you're breaking the law. But it's hard to take notes and listen to people extensively. But those are the outline rules. But when you say the person believes in his hallucination, I think what's important, at least from my point of view, is to first make sure that the person does not have a real disease. Now, there are real diseases that could create all of the symptoms that characterize the different categories of mental illness, except these are physiologically based. And in the DSM, which I'm sure you're familiar with, obviously, they used to make a point of saying everything listed here does not, in our opinion, have an organic basis. Of course, if it did have an organic basis, it would no longer be a mental illness. It would be a neurological illness. Are you with me here? Mm-hmm. So when people say, well, mental illness is characterized by a lesion in the brain or too much chemical of this or too little of that, if we really knew that that was the case, again, that would not be a mental illness. It would be a physiological illness. And again, the rules that apply to treatment of real disease would apply. And what that means is that you aren't treated against your will. You can have cancer and refuse treatment. You have to have permission. And in the world of psychiatry, that's taken away from persons because they say that they lack insight into their disease. Now, I don't know if you know a psychiatrist. His name is E. Fuller Torrey. And he was at one time a very strong disciple of Thomas Szasz. And then he flipped and went to the other side and has been a very strong supporter of involuntary commitment. Well, I went to a talk that he gave, and I had a little bit of a confrontation with him there. And he said, look, the person lacks insight, and we have to restore insight by giving him any number of neuroleptic drugs like Thorazine or, all the different Mellaril, any of those things, Zyprexa. And I said to him, well, now let's say you give the drug to this person who you call schizophrenic, and you say that he's schizophrenic because he lacks insight into his disease. He doesn't know that he's sick. And he takes the drugs, he complies, but after 6 months or so, he feels fine, and he says, I no longer want to take the drug. You have allegedly restored his insight. What do you have to say to that? Why would you keep forcing him to take a drug? And Tori's answer is, well, his insight was not completely restored. I mean, this again is the heads I win, tails you lose. The psychiatrist always wins. And even though the guy has been on the drugs, which allegedly restores insight, which means he agrees with the psychiatrist, he must continue to obey the psychiatrist. Otherwise, he's still sick. Now, this isn't, I mean, look, you're not going to stop having diabetes or cancer because you don't do what the doctor says. I mean, the disease has a specific progress and nature itself. It's not a matter of agreeing or disagreeing with your physician. But in psychiatry, what we see here, and this is what Tom pointed out for years, is that psychiatry is really more about social control. It's not about the treatment of medicine, certainly not scientific medicine. The role of choice is key. It's very, very important. And so a person has a right to refuse any and all treatment. There are a couple cases where we do treat people without their consent. And I've lectured on this quite a bit over the years. First case is when a person is a literal child. For example, she or he needs to get an injection because he or she does not understand the consequences of refusing that inoculation. The second case is that the person is contagious. And we give a shot or treat the person for a disease like highly contagious viral meningitis or whatever, because not so much that he might die, but he could infect other people. And the third one is that a person is literally unconscious. So if you're walking across the street and you're an American visiting in London and you look right instead of left, you're going to get whacked and you'll be unconscious on the ground. Now, when the ambulance arrives, they're not going to sit around and say, do you want to have treatment? Do you want us to take you to the hospital? Well, the person's out. You can't wait until he gives consent because he might die. So in that case, unconscious, being a child, and being contagious are situations where treatment may proceed without consent. It's not that they object, except children could object, obviously. Well, actually, even in contagious situations, they could object, but you don't have a right to infect other people. What psychiatrists have done have taken those three conditions, which are literal conditions, and twisted them, made metaphors out of them, so that what they say is we have to treat this chronologically adult person as if he's a child because he doesn't know what he's doing. In the second condition, we have to treat him because he lacks insight. It's like he's unconscious. And in the third situation, we have to treat the person because he might kill someone else, which is the equivalent of a contagious disease. Now, many people say they're dangerous people who are mentally ill and we've got to do something about them before they hurt someone, even though they haven't committed a crime. The fact of the matter is, and no matter how many times I say this at conferences, people agree, and yet they proceed as if what I'm saying is simply not true. No one can predict whether one person is likely to harm another with an accuracy beyond that expected by chance. We can't do it. So did you ever see a movie called Minority Report with Tom Cruise?
Absolutely. The precogs?
Exactly, the precogs, where they had these psychics who could predict who the future and whether this person was going to hurt somebody else, etc. That's kind of based on a similar idea as psychiatry, as if people can tell that they're going to harm somebody else. But bottom line is that we cannot. And when I confront psychiatrists on this, they say, well, you're right, but we've got to treat them against their will, nevertheless.
Absolutely. And often when the media are very good at picking up on that, but when something's happened, a crime has been committed, and it's often saying, oh, well, if we now look back at the history of the person deemed to have committed it, and maybe there was some signs of, in quotes, mental illness or something where you go, oh, we should have been able to predict this. There's often this sense of looking back thinking that to some extent we should have been able to predict this and therefore stopped it.
Exactly.
And it's often, it's something that's just not possible looking ahead into it.
Exactly.
I wanted to ask then, Jeff, would you have said then yourself and Thomas Szasz would be still regarded as maverick? I mean, are there others? Is there an increasing kind of movement now that sees this as an alternative view to mainstream psychiatry, or is it still something which, say, you're seeing as kind of mavericks and out on a limb on your own with some of these ideas?
I think we're still considered mavericks, heretics, but not as much as we used to. And for example, in this book that I've just come out with, we've got about 10 people from different backgrounds who are speaking the way Tom would speak, and you wouldn't see this type of thing earlier. I think, and I talk about this in a chapter that I wrote about in this book, to eliminate psychiatry, and I differentiate here between institutional psychiatry and consensual or contractual psychiatry, and Tom did too. He said, I believe in psychiatry between consenting adults. He said, if somebody wants to take drugs or be prescribed drugs, by all means, they should certainly have a right to do that. He said, I don't think these are conditions that require drugs. And people say in response, well, the person feels better after taking the drug, so he must have needed that chemical. And that is wrong thinking. If I feel better when I drink a glass of wine in the evening, is that because I'm suffering from wine deficiency? No. I mean, any number of drugs can have effects that are good or bad, but that doesn't mean that we need them. But what's going to be very difficult about eliminating institutional psychiatry is the investment that they have in their work. Think about how much work they did to become psychiatrists. And you know that the suicide rates among psychiatrists, actually more female psychiatrists, is among the highest for members of the medical profession. And, I think you can only speculate about why that is. I suspect that many of them come to the conclusion that what they're doing is basically fraud. A lot of them end up, after pushing for so long to have all these drugs acknowledged as treatment, they end up prescribing for Prozac deficiency or Prozac or Valium deficiency. They're not being reimbursed for talking and listening to people, and it becomes a very dry and boring practice. Also, having to coerce people into treatment becomes rather unpleasant after a while. So I suspect they come to the conclusion that they've made a huge mistake in terms of career. And I'm sure you're familiar with Fessinger's work and the work on cognitive dissonance. When people have invested in a particular work or discipline, and then they find evidence that contradicts what they believe to be true, it's very difficult for them to admit that they've made a mistake. And in fact, what they may do is strengthen their belief in, say, the medical model of mental illness, even when they see, or as a result of seeing, that it's not accurate. You know the book When Prophecy Fails, where these social psychologists studied cults that predicted the end of the world. And very shortly, when their followers, and they went into a cave and got ready for the end of the world didn't come. And so you would think they all stopped believing in their leader. But they did just the opposite. They said, the Lord works in mysterious ways. We're being tested. So we should strengthen our faith, not reject it. I think that happens among psychiatrists, too, who believe they've made a mistake. There are very few, and I do know some of them, who come to the conclusion that, yes, they made a mistake. They can still practice psychoanalysis or psychotherapy, but they don't want to practice the prescribing of drugs. And I think that they're very courageous people. One of the psychiatrists who was very close with Tom Szasz, Ron Leifer, I dedicated the book to him. He's in a bad way neurologically because he had a stroke that was pretty bad. But he came to that conclusion, and he was persecuted by American psychiatrists for rejecting the idea of mental illness and not wanting to use drugs. I mean, they really went after him, and they tried to take away their license for disagreeing with the status quo. And that's, of course, what happened with Tom Szasz. And I detail all of that in the only really accurate account of what happened to Tom Szasz in 1963, right after he published The Myth of Mental Illness. The head administrator for the state of New York for the Department of Mental Hygiene ordered the chairman of the Department of Psychiatry at Upstate Medical University in Syracuse to fire Thomas Szasz for writing the book, The Myth of Mental Illness. And he was a tenured professor, too. And Tom asked a man named George Alexander, who was an assistant dean of the School of Law at Syracuse University, to act as his attorney. And they met with the president of that medical university. And George Alexander told me that the meeting went like this. George Alexander and Tom Szasz met with the president of the university to complain. And this is a funny story because George said to the president, listen, you have violated my client's rights to freedom of speech, to his First Amendment rights of academic freedom. And he said, would you like another Scopes trial? Because if you would, I will show the world the monkey that you are. And right there on the spot, the president protected Tom Szasz and fired the chairman of the Department of Psychiatry. This was a big deal because, here he was being punished for speech. And that has happened to me, too, at different universities where I've been told that I better start talking about how mental illness is a disease and not talk about Szasz's work. The same thing has been true for how I teach about addiction. I wrote a book called Addiction is a Choice, in which I point out all the studies that show that people can stop using drugs, regardless of how long they have used them. And when I was confronted at Hopkins for doing this, the dean said, you want to show me where you get some of these studies from? And I came prepared and I said, yes. I showed her the studies and I said, you'll note that these were conducted at Johns Hopkins University. You with me?
Yeah.
The irony. And in terms of the book, then the edited text now, Jeff, is that one that's already out or is that soon to appear?
Which one?
The latest book, the latest text, which is the edited text.
It just came out 2 days ago.
And remind us of the title of that.
It's Thomas Szasz, The Man and His Ideas. And the editors are myself, Henry Zvi Lothane, a psychiatrist who is a follower of Thomas Szasz's, and also Richard Vatz, a close friend and colleague at Towson University, where his expertise is in rhetoric and communication, which, interestingly, this is what Tom did with analyzing psychotherapy. He said, this has more to do with rhetoric or influential speech than it has to do with scientific medicine. So this book is just out. We've got 10 different contributors. They are absolutely excellent. Some of the people from England, you probably know them, Joanna Moncrief. Do you know her?
Yeah.
Know the name, yep.
Yeah. She's contributed, and there's an expert on semiotics, Susan Petrelli, and a very excellent essay on addiction by Bruce Alexander.
It was an absolutely brilliant read, Jeff, and I recommend it to everybody.
I sent you the Unbound Galleys. That's right. Yeah. Okay.
We will I really hope we can get you back in the future and discuss about addiction, because that is going to be an absolutely brilliant podcast and just as interesting as this one. I think we're going to call it, draw this episode to a close.
Sure.
But thanks for joining us, Jeff. We've had a brilliant chat, and we've covered a huge amount of information. And, you know, this is exactly what this podcast is about, you know, existential issues, about, you know, controversial issues. But to be honest, for me, Szasz is an absolute hero. You know, and if anybody, you know, if you haven't read The Myth of a Mental Illness, I think it's a very important book.
Right.
Blows open psychiatry. And again, you know, your books are brilliant. You know, the addiction book is absolutely brilliant. And, you know, there are people questioning these things, and, you know, we should be questioning these things.
Yes, of course. Absolutely. Well, it's very
that completely. Yes, thank you, Jeff. Appreciated. Thanks for your time.
Thank you much. It's been very enjoyable for me.
Thanks for the time, Jeff.
All right. Thank you.
All right. We'll say goodbye.
All right. Bye-bye.
Bye-bye for now.